advertisement here.
No, okay. I'm Annie. I've been an IR tech for 20 years now. I trained in Virginia and then I moved up to Northern Virginia, and I have been working at a level 1 trauma center and comprehensive stroke center ever since then. During my time there, I've had a few different roles. I was a clinical coordinator of the department. I then moved into a internship role where I run an internship program with cohorts every single year to train radiologic technologists into IR. So we usually have 4 to 6 students. This year we'll have 6.
That's a lot.
It's a lot of students. So that was my little COVID project, along with our entire department. I always say it takes a village to build something to that magnitude, and it definitely took our entire department. So I've been running that ever since. We right now have a 100% pass rate on the VI exam, which is a very hard test to take if anybody's familiar with that one. But yeah, that's what I've been doing ever since. And I really have a passion for education, so I wanted to reach more people. So that's why I started the In the Loop brand. And a lot of people would DM me, or just I would see them at conferences and say, "Hey, can I have any of your stuff? From your hospital program?" And I don't own that stuff, so I started to do something else that we can get in the hands of people. And we're starting with our non-vascular book, so it's truly been a joy to make this.
I'm excited. Do you have your bachelor's?
I do.
Right? I thought so.
I do. I actually did my bachelor's while I was in the hospital, like while I worked at the hospital. So my background is an associate's program for radiology, which at the time, I'm like showing my age, but at the time they didn't require prereqs before radiology programs.
I remember you saying.
I did them at the same time. So I did radiology school. That's like a traditional 2-year program during the day. And then at night, I took night classes for all the prereqs. So I definitely would not recommend that.
You just have to like finish it before you get your degree, right?
Yeah. You have to finish it. And I did it all within the 2 years. It was a lot. It was a lot.
Someone was asking me on TikTok Live yesterday. She's in college and she's a psychology major. And she only has 1 semester left. And she's like, I want to work in the cath lab. Should I just quit now? I was like, no, finish your degree. Finish your degree, and then it'll always be there. But oh my God, how much debt are you in for almost just giving that up? No.
I know. It's insane. So yeah, I started working, and then it's always been one of my goals, right? To have my bachelor's. And I was like, you know what, I'm going to do it. So that was my second COVID project. I had a lot of things going on, but I did
do it. I got my master's during COVID.
Right.
Did you ever work in regular X-ray or no? You went straight to IR?
Not a day. I went straight in.
Yeah. Well, that was nice. Were they pretty welcoming to new grads at the time, or? Because I know sometimes it's hit or miss. Sometimes they want some type of procedural experience or something, but not always.
Well, I went to a specific program to teach me. So yes, they were welcoming because I was accepted into the program, right? And it's what they do. It's the oldest program basically in the country to train IR techs. So we went there and I learned cath lab, IR, and neuro IR. I haven't used the cath lab training since I was there.
But I mean, some stuff overlaps, but yeah.
Yeah, some stuff does overlap, but if you throw me a stomach right now, I don't know how I would do, to be honest.
Wire catheter, wire head catheter.
I would figure it out, right?
I got it.
Got it. But I've been doing neuro IR and vascular and body IR ever since. So that's kind of my background.
Yeah. So your neuro is the place in which you currently work. Yeah. Is your neuro and IR team combined? Because some places have neuro separate from their IR teams, which I thought was interesting.
Yeah, it's combined right now. There's been talks over the years. Sometimes we get new physicians, they're like, we should really do a dedicated team. But that it never really comes to anything. We've just kept it. We've got like 22 techs and we all do everything. Body, vascular, and neuro. So
that's a lot of call.
It's a lot. We've got separate teams, but it's 4 people on call every night.
Yeah. And there's a lot of cath lab people, and they'll probably pop in here and say this. They take both STEMI and stroke call together, which I don't know. I feel like is a little questionable. You know, who do you actually prioritize? Like, if you actually had 2, who are you prioritizing and how? Because, you know, hospitals don't divert. They should, but they don't a lot of the times. They're just like, yeah, we'll just finish this one up and then we'll get them set up in the next room. You know?
Yeah, that's a little dicey. We always have a backup team, like where I work, but there's always somebody to do it.
There's only one hospital here out of the 30 hospitals that has like a second call team, I guess is what you would call it.
Wow. Yeah. All the hospitals I've heard of up here, everyone at least has like a couple people on the backup team for that.
As you should. I mean, I get it from a hospital perspective. They're like, oh, I don't want to give all these people money to not get called in, but a delay in care lawsuit is a little more expensive, don't you think?
Yeah, that would be great.
Which has happened here. That has happened several times, actually.
Oh man, that's scary.
All right, so I will switch over. I have your book in front of me, but yeah, I don't know whose lighting is better. I was like, you can talk and I'll do the like, you know, during children's book hour or like
I love this.
And flipping the page. So walk through for me and you can kind of have it in front of you. The table of contents, your choices regarding that, or if you want to just start with why, because this is a lot. I mean, this is a huge book of why you started non-vascular, because you did mention neuro and vascular, you're kind of separating out a little bit. So why are we starting here? What were some of the choices? Will the other books, you know, you think repeat anything, or is all of this really only specific to what you have going on here? So I'll let you start.
Okay, so I think a lot of people know that this is part 1 of a 3-part series. So I did start with non-vascular because these are what you would call the core IR procedures. These are all of our organ procedures. And then I also included central venous access in this book because that's also a very major thing that IR does. It doesn't truly fit into the non-vascular bucket, but it's what you're going to be doing, not all day, every day, but it's going to take up a good portion of your day if you work in the IR suite. So I just thought that that should be included into this book. So in the non-vascular book, we start out with patient care. Now, patient care will probably be a recurring theme in the vascular and neuro, but we're going to deep dive probably into the thrombolytics more in the vascular, and then some of the neurospecific drugs. We'll dive deeper into that into the neuro book, but that will be a common theme because obviously we deal with patient care in all 3 areas.
So you say it'll just kind of be relevant, specific to the rest of the procedures that are in that specific book. That makes sense.
Yeah. And in the patient care section, in this book, we have our vital signs, basic rhythms, lab values, our sedation that we use in the IR suite, and then all of our commonly used medications and then reversals of those medications. We also touch on contrast agents, what the reactions look like, and any complications from contrast.
Yep, I see that.
Yes. Our next section is
I love this one, by the way.
Right? Okay, I was sweating profusely. That's like me. And you could tell by the look on my face. I'm like sweating. I was sweating in my house. It was like 100 degrees. Our air conditioner was broken. And I'm like, I need.
Oh, yeah. These gowns don't breathe. I forgot.
Yeah. And like, I work on timelines and I'm like, I have to get this stuff done. And
that's what
meanwhile,
I feel like doing checkoffs.
Yeah. I'm like, meanwhile, I'm sweating under my mask. Anyway, that's in the sterile technique section. We go over the whole sterile environment of care, how you gown, how you glove. There's actual pictures in there from like a technologist point of view. So if you're brand new and you want to learn how to put gloves on, I did the picture specifically on how you would look down and look to put them on.
Yeah.
You
left hand's on your left, right hand's on your right, not patient left, patient right. Yeah.
Exactly. So it's very easy to follow along and visual. I go through the prep agents that we use for different procedures and different patients because it is different if you've got an open wound or any allergies. We review in here how to open supply sterilely, how to pour liquids onto your tray, and how to set up your back table. The equipment section, I did a broad overview of a lot of equipment that we use in IR. We deep dive into all the different needles because in IR, we are accessing organs, not just blood vessels. So there's different gauge size, different lengths, just different uses for different needles and different tips. I mean, there's just so much that we go into. We have many pages of wires and catheters, why we use different wires, why we use different catheters, just situationally.
So I like that you add because I do this, I'm going to do this in the intervention manual for some things that I know it's a little undervalued, but the wire characteristics, just because a lot of the times we suggest things, but we don't always know, like, okay, if the J wire didn't go, then I'm going to recommend a glide wire. What's the difference between the stiff glide wire, the one with the, what is the word? Floppy tip. This.
Like a Benson or a Newton. Yeah.
Right. And why that certain quality matters, because what if you don't have them, right? Like what if you're out of stock or them and they're on back order? This is really how you learn to suggest other pieces of equipment, is that you know the characteristic of it, not just, oh, well, if we do this, we do the glide, but you don't understand what the value of the glide wire is. Does that make sense?
Oh yeah. And if you're
buckling,
I think
it's important.
Yeah. And if you're like buckling, you want something stiffer. Yeah.
Right.
Absolutely. And we all don't have the same stuff.
No. Or we just don't know the name of it. We're like the blue package on the bottom right-hand side, that one.
Exactly. Visual people. Also in the equipment section, we go through like a how-to of doing certain things for our brand new people. So that's going to be looping wires, walking catheters out over the wire, and removing air from a syringe. All those beautiful things that you need to know when you're first starting out. Let me see. Also in the equipment section, I review balloon and stent basics. So what's the difference between compliant, non-compliant, semi-compliant, cutting?
Is that on the VI exam? Because that's on the CI and the RCIS exam. Yeah,
absolutely.
I figured.
Mm-hmm.
Sorry, I'm just going to swirl and keep interrupting, but you keep.
No, that's fine. That's how I live my life. I've got two little.
You keep going.
I've got two little kids running around, so I don't think I've said a complete sentence in 4 years, to be honest.
Oh, I like the. Isn't the MedRad so hard to draw? I really struggle.
Oh my gosh. Yes. So I'm glad that you showed that because I review on how to set up the MedRad injector. Mm-hmm. And then I also go through how to set like the flow rate and the volume, what that means, what is a rate rise, what does that do for us, why do we care, what the PSI is. And then another important one in there is in the imaging section on how to perform a cone beam. And I also review how to set the injection for the cone beam because that one's a little tricky for people, just calculating from your spin time and your flow rate, how much volume you need, what delay do you need to make sure that the C-arm is spinning the entire time, because otherwise
you just or your injection a whole bunch of contrast and radiation.
Well, yeah, if your injection's not going for the entire spin, then your reconstruction is not going to be good.
Yeah.
So like making sure that injection is right is key for sure. What else on the imaging? So we go through every single button.
I like the buttonology. I don't know if that's a word, but it is now.
It is now. That's actually one of my favorite pages. Yeah. It's so cute.
Well, because this is stuff we draw on like 100 times Zoom. And then we zoom out and we're like, oh, you know what? I don't really think they can even appreciate what I just spent time doing, but I can appreciate it.
Thank you. I know. So on that is like the tableside controls that we use. Mm-hmm. And that is a Philips and a Siemens. And then what button corresponds for each system and what it does. and why you use it.
I like this.
Yes, that's absolutely one of my favorites.
Sounds color coordinated, which I
Mhm.
appreciate.
In that imaging section, we do how to perform a run, how to get a roadmap,
We do
how,
post-processing stuff too.
yeah, post-processing, getting a measurement, making sure that you're doing the measurement correctly. I also review how to calibrate for the measurement. I know not a lot of people do that, but if you want a precise measurement,
Yeah, no, you should.
you should probably calibrate.
What's the difference?
Also reviewing some radiation safety in here and how to reduce your dose as being part of a procedural suite that uses radiation all the time is really important. And then the last thing in the imaging section is ultrasound basics. So how we're holding the probe, what the different positions are. Yeah.
And to clarify, well, I don't know actually. Are
Mhm.
you guys using ultrasound mainly for access and like image? How do I say this? There's a difference between ultrasound use for diagnosing,
Mhm.
right? And ultrasound use for procedural guidance. Does that make sense?
Yeah, so ours is procedural guidance.
Yeah.
For IR. No, we
I'm
do like it might
clarifying
have
for people are like, there's echo in it. There's ultrasound in it. No, it's not just sonography. It's
yeah,
specifically related to your procedures.
right. I tell people like IR techs are not just IR techs. We are also like fake ultrasound techs and CT techs sometimes.
Yeah.
Like I just know enough
Because you have to use
to be
it.
dangerous, just to get access. But it's important to be able to adjust the image to make sure that you can see the needle tip and you've got your area of interest in the middle, just to make it easier for the physician. So you need to know how to work the machine.
Yeah. No, I appreciate that because like when we first
Mhm.
started doing pedal access, because we got two physicians who use it, they were like, can you hold the ultrasound probe? I'm like, sure. And they're like, I can't see anything. I'm like, I don't know what I'm doing. You just told me to
Right.
hold the probe.
Right.
I
And
have
it's
no
like,
idea what I'm looking at.
right. And it's like, what probe's better for
Right.
what area? So I review
Shallow and
that
deep.
too.
Yeah, I see that. I could learn. Well, I need to learn, I guess.
You've got this.
Oh, biopsies.
Yeah. So and then after the imaging system, that's where we break down into basically organ system, um, where everything's kind of grouped together. So I start with percutaneous biopsy. If you work in IR, you know that's a big portion of our work. Um, so how to operate, why are we doing a biopsy? What's the difference between a biopsy and an aspiration? What are we looking for? How to use the equipment. So how to prime and like cock the biopsy gun. I do touch on transjugular liver biopsy in here just because I did believe that it belongs with that family. I will probably also put it in the vascular book. But if we're talking about biopsy, you've got to throw transjugular in there, even though it is not technically a non-vascular procedure.
Oh, yeah. I guess you're right.
I
But I
know.
mean, the technique wise and like
Yeah, it's just
the
a
purpose of
longer,
it is in the same area.
yeah, it's just like a longer needle.
Yeah.
Just for patients who are coagulopathic. And then we also have lymphangiogram in here. That's a diagnostic procedure where we look for chyle leaks. And sometimes we even go and try to embolize them, which is a fun one. Like usually like 5-6 hours.
Really? Just
Of
because
fun.
they're so small and there's so many of them?
Yeah, and the lymph just moves so slow. So
That's
you
not
just gotta
boring.
wait.
I always
Yeah.
thought IR procedures were relatively short.
So most of them are, but when you get into like lymphangiograms or a lot of our vascular work, it's long. There's our
Yeah, I mean,
lymphangiograms.
vascular's long for sure.
Yeah. And then next, drainage. So we start with paracentesis and thoracentesis. I review chest tubes, tunnel drains, abscess and fluid drainage, and then how we
Can you hear
maintain.
that? I'm sorry. I don't know how to open a book like a normal person. Repeat your last sentence.
Oh,
From my recording.
just how we review parathoras, chest tubes, tunnel drains, abscess, fluid drainage, and then how we maintain them for checks and changes and how we can best set that up to reduce radiation with using like the long extension tube to stand back. Just little tips and tricks in there to make things easier.
Do you guys ever do any bedside stuff with
Not at
portable?
my hospital, but other hospitals that I've worked, and I know for a fact other facilities do bedside all the time.
Yeah. I mean, I've done bedside, which is why I asked, but it was always, I mean, it was kind of a questionable physician, so I never really knew if that was a no-no or if
Yeah.
we were just doing it. But also, I mean, you have really sick patients, right? Like some of our ICU, CCU patients where they have so much going on, it's almost more of a risk to move them, you
Yeah.
know? But they're also usually in beds where you can't get a portable under it anyway.
No,
But you could
you
do ultrasound. You do a lot with
just a
ultrasound.
lot of that fluid stuff, you would just bring an ultrasound with you and have your little bag of tricks and go up and do it under ultrasound
Yeah.
guidance. It's
Yeah.
the same principles that you would do in the suite. Some people we even just bring into the procedure room or do it in the recovery bays without even putting them on the table because we're not going to be using x-ray. So
This would be me in my car when I get called in. Can you do this bedside? Okay, let me take a picture of this page and then go shopping of what I
right,
need to get before I go over
exactly.
there.
Exactly. Yeah, every procedure has a quick reference page. So that's something that you can look at very quickly and see what supplies do I need? Why would we be doing this? Why would we not be doing this? What lab values do I need to look at while I'm reviewing the chart real quick? And yeah,
Oh yeah,
it's very it's very easy to look at.
yeah, I like that. I like that because a lot of people, when they asked me about IR stuff, they were like, "I just need to know what I need to pull." So
Yeah,
that's really helpful.
yeah, I'll be having something come out soon for that one too.
Yes, you will.
Yes.
Did I
And then
set you up for a plug? Maybe.
I love it. It's fun.
Oh, and you
Oh,
have certain, so I have noticed, I don't know if it's on all of them or just the relevant ones, but you have like relevant tables set up by procedure. Because you have
oh
tables
yeah.
set up in the, what is this?
Sterile
What is
technique.
the red section? Yes, in the sterile technique section. But then you also have it relevant for whatever procedure it is in the procedure, because obviously you're going to have different stuff. So
Yeah.
I kind of just noticed that.
Yeah, I put that in there because I put my supplies in the same place in my tray every single time. Oh, that was my tube check.
Yeah, I
Um,
like it.
and I can just visually look at the tray and tell you what I'm missing.
Yeah,
You know, I'm just like, oh, I know that I always keep my
something goes
dressings.
here.
Yeah, my dressings go right here and they're not there. Hey, can I get a dressing? Thank you. That's why I put that in there.
I think that's a smart way to learn.
Yeah, so people can kind of see what it looks like on the tray.
Yeah. All right, I'm in ablation, right?
We're in
Did I
ablation.
go too far? Okay.
No, that's perfect. So we
We're
do.
only halfway.
It's so much. Well, I are so much. People are like, oh my gosh, it's 3 books. I'm like, yeah, it's 3 books. You should see how big the non-vascular is.
Yeah.
There's just so much to review. And I think you really need to know the why behind what you're doing. So that's why we
I
got
mean,
to
I'm sorry. If you're sticking a needle directly in my organ, I sure hope you know where it is and what you're doing and know what you're
right.
looking at.
I hope someone looked at my coags.
Yeah.
So the ablation section, so ablation and IR, we do cryo, RF, microwave. Mainly, there's some new stuff on the horizon, like histotripsy will be coming soon to some hospitals. But we review what is the difference between them, why, when are we going to use one over the other, and how they work.
Mhm.
Uh, we didn't do ablation at my hospital for a very long time, and then we brought it in, and I'm like, oh, hold up, let me get my
Is it
paper.
considered like higher risk or places that have surgical backup, or it doesn't matter? It's
No.
just who has the equipment?
Yeah, it's just who has the equipment. And a lot of times they would do ablations at some of our smaller facilities where we would get
Mhm.
more of the complex cases. So when we started doing them, I'm like, let me get my pen, let me do my papers. Like a couple of
Yeah.
years ago, I'm like, why are we doing that? What organ we use that one in? How does it work? So that's what I review in that section to kind of
Yeah.
hopefully clear that up in people's heads on why we are doing what we're doing and when would you pull different machines and probes in the room.
Gotcha. Oh, we'll talk about it later. I just identified a distractor answer that was on one of my cryo questions on my RCES. And I was like, I've never heard of this before. It's because it's an IR thing and not a EP thing. And it confused me
Oh my
because I
gosh, what's
didn't
the
know
term?
that you guys did cryo. Like I didn't know other places used it outside of EP.
Yeah, and
Yeah, so I got that question wrong.
I didn't really know people used it outside of IR. Look at us with our like narrow focus.
Yeah. And same thing. A lot of your temperature goals and stuff are the same because tissue is tissue,
Right.
but it's a different device. So like there is point cryo, but a lot of it's balloon to occlude like the pulmonary veins and then do it.
Yeah.
So it is a little different, but I'm so mad I got that question wrong. Sorry. But I hadn't heard of
At
it
least you
outside of it.
understand now.
Yeah, I do. Sorry, moving on. What's MW?
NW, where?
Oh, blah, blah. Microwave. Microwave ablation.
Oh, MW microwave. I thought you said NW, and I'm like,
Oh, sorry.
NW.
MW.
MW
That's new for me
microwave,
too.
microwave ablation, and then radio frequency ablation.
Are they catheters? Are they balloons?
No, it's a probe. It looks like a thicker needle. That's what ours look like.
Interesting.
I know.
I need to write a note. Sorry,
Yeah.
this is blowing my mind. It's all of 2 pages, but it's blowing my mind.
I know. And then some of the RF stuff will use like the outer portion of a needle, like the cannula part, and then you put the like smaller probe through that.
Oh.
And then plug and play, as I tell people. Plug it in, adjust your settings.
Like laser. Yeah.
Yep.
Probe, ice ball, cryo.
Yep.
Huh. Okay.
Yeah, and then the probes, there's different like cryo probes that are going to make a different shape ice ball depending on, and you're going to use one over the other depending on what the tumor looks like.
I knew, and I feel so stupid because afterwards I was like, Shauna, I put ice ball. What's an ice ball? And I was like, I just put it because cryo. She goes, that doesn't happen in EP with our catheters. I don't know what that is. And I was like, I don't know what it is either. But I chose it because I was like, oh, ice ball cryo, but it's an IR thing. Ah, whatever. I feel so dumb. At least it's a real. I was like, this is such a weird answer choice. Kicking myself. Okay, pain management. Oh, this is where the nerve blockers are, isn't it? Oh, wait, I lost you. Did you mute yourself? How'd you even do that? Or is someone calling you?
No, it like
Oh, I can hear you now.
Okay.
That's weird. Did you say a curse word or something?
No. I'm getting better since I have small children.
I didn't.
There was like a little pop-up that said like turn on reactions. And maybe
maybe it just muted you when it popped up. Because we're very animated. It wants to put like balloons and happy faces and stuff while we're talking.
I just want to be like, hands, just stay down.
Yeah, no, it's not gonna happen.
Never. Okay, pain management is fine. So reviewing vertebroplasty, kyphoplasty, the steps, what is in the kit, and then touching on nerve blocks, because depending on your facility, you might do some nerve block work, which is pretty straightforward, but we do review it in here on what you need.
Yeah, I appreciate that. My mom's getting a nerve block, and she was like, "Do you know what this is?" I said, "No, I don't know what that is."
Yeah, a lot of times they'll do the nerve block to see if it works, and then if it works, you might do an ablation of the nerve. So you're going to test it first with like lidocaine and a steroid, and then if it works, then we know like we can bring you back and burn that nerve pathway and hopefully give you more time of relief, because the nerve block itself is not going to last.
Yeah.
But if it worked, that's awesome, because you can then most likely get an ablation. So
yeah, ablation's permanent though. That makes me nervous.
I know. It made me nervous too, but it works. And you're not doing like a major nerve, right? Like you're not going to drop their diaphragm or something.
Right. You hope. No phrenic nerve ablation.
That would not be a good thing. And people that have like a bunch of pain, like cancer pain, we do that a lot of nerve blocks for them.
Yeah.
Mm-hmm. And then we get into the big meat and potatoes of IR after this. So central venous access.
Oh, so much to go.
Okay. I know, because this is the meat. This is the bigger stuff. So central venous access, PICC, non-tunnel catheter, tunnel catheter, port, the steps. So we review we have that quick reference on all this as well, reviewing why we're doing it, why we wouldn't do it, what lab values we care about, the supplies you need for each of those, the steps of each procedure. So that's all drawn out visually, where, you know, I do the step with the lidocaine, then the needle, and the wire going down. And then if that case needs you to upsize your wire to put the catheter in, we do that step too. So it walks you through step by step of the procedure. Because as a, I mean, this book is for anyone new to IR or someone that just wants to have a better understanding of what they're doing. But as a technologist, it is our job to make the procedure more efficient and quicker and to support the physician. And you have to know what the next step is.
Yeah, I feel like anticipation is something a lot of people struggle with.
So that's why on every procedure in here, we review the steps, because you need to be thinking about the next one while you're doing the current one.
Yeah, and you need a way to review it besides only when you're scrubbed in.
Exactly. And we review troubleshooting of all these cases for central venous access, what to do if the wire's buckling. We have an arrhythmia. Why do we have an arrhythmia during the central venous access? Oh, it's because we need to pull our wire back. Yeah, the wire's tickling the heart. So stuff like that you learn inside the procedure suite, just doing the cases. Next, we pop into the urinary section. We do a whole system overview and review the anatomy on each section. And then we dive into percutaneous nephrostomy, how we maintain those tubes. Also, like the difference between a percutaneous nephrostomy, an NUS, a double J. How do we do the puncture? Where do we puncture? Everything like that. What needles we use for that? Doing percutaneous access for lithotripsy, where some facilities do all of that in the IR suite. They get access, upsize, and do the litho in the IR suite. Some facilities will just get access and then put a dressing on and then send them to the OR. And then they do the lithotripsy portion in the OR.
Why do they do it in the OR?
Because the urologists do it.
Oh.
Mm-hmm.
Territory fight, not because there's
always yeah. Yeah, so they'll do that. We review how to handle an ileal conduit patient. So that's when we take a portion of the bowel and they make like a false bladder. So but sometimes we get narrowings in the ureter where they tie it on and we have to put tubes in to keep it open. So how we manage that. We also do some stone extractions using baskets. So we review that, and ureteral embolization for people that have persistent leakage. That's a lot of cancer patients.
Yeah.
And then the last part of that section is suprapubic tube placement. And then we dive into biliary drainage, where we review the system again.
Green is such a good color for that.
Right, it has to be green for bile.
Yeah, it does. It works well.
Yes, percutaneous biliary drain placement. So we review what approaches we use. Sometimes it's right side, sometimes it's left side, sometimes it's both. Why is that? What are we doing here? Steps of that procedure. The drain maintenance again. A rendezvous procedure where we use a really long wire so they can snare it in the GE lab and do the rest of the procedure. So we are working hand in hand with them. We also do ballooning and stenting in the biliary tree for some end of life care there. Brush biopsies, percutaneous chole tube placement. And then our last big section is gastrointestinal, where we review putting in G tubes and GJ tubes and jejunal tubes. All your feeding tube stuff is in this section, which is pink, because why not?
Yeah, because, intestines are pink.
And then we rounded out with all the references. Though I built this book from a ton of different resources, devices, journal articles, textbooks. My stack of textbooks here is wild, but it was a lot of fun to build, and I want to make sure that I'm giving everyone accurate information. So I check and double check and cross-reference different sources there. And it ends with a picture of me and my dog.
Well, and I think it's important that, I mean, people outside the US are going to be a little different. You know, they're going to have some different pieces of equipment. But I always think it's important whenever you're using a resource that somebody actually referenced and read the instructions for use in the IFU. Because I feel like, before I was an educator, even now, there's a lot that I learn when I read the IFU as an author and I go, oh, I didn't know that. Oh, I didn't know that. Like when I read about the spider FX and it's heparin coated and there's no warning for a heparin allergy, but filter wire isn't coated, but it has a warning for a heparin allergy. I was like, what? But I think when you're trusting somebody's resource, that's like the number one thing you need to look at. And I never take offense when people ask me, like, where do you get your information from? I'm like, thank you for asking. You know, I talk on label, I look at publications for expert consensus guidelines because there's a million ways to do certain things, and you have a lot of options in here of different access points and different things like that. But you have, this is why you might choose this one over this one. I'm not saying one is superior to the other. These are your options, and this is why. And these are the references where you can find them. You know, I think that's important. Personally, it takes a lot of time, as you have experienced, but I think it's the best way to teach someone is you're putting your own tips and tricks, yes, but you're speaking on label, on brand, I guess, to make sure people are getting universally correct information.
Absolutely.
That makes sense.
Oh yeah, I learned so much reading the IFUs. I'm like, oh, that's not how we were doing it.
Yeah. Yeah. And you go, oh, you know what? I made this page based on me doing it this way. I need to change that.
Yep, that's not right.
Yep. I just figured that out today when I was talking about the lithotripsy stuff. And I said, oh, I had to ask I just messaged the VP of the company and I was like, what is this? Like, where's the console? What does it plug into? And he goes, it doesn't plug into anything. You just use the balloon. I was like, why is this a major thing missing from all of your videos? And I'm sitting here like, what does it plug into? And after 3 months, finally he answered me. He was like, it doesn't plug into anything. So, oh, I wish you just told me that from the beginning. But I had it written in there because I actually just thought that it did plug into something. I was like, wow, I feel dumb. So I'll get to people's specific questions. You can take a water break for a second if you need it. I need a water break.
It's okay.
All right. So, we'll go into future ones later. Someone asked, did you make this yourself? Because people do ask that, because people don't. So Annie, did you make this yourself?
Yes. And it's funny. I tell people like, this is my 4th redesign because I am the way I am. And like, I just have to, just a little bit of a perfectionist, but yes, I made this myself. This is the 4th redesign before we went to print.
Not even that you were great with it, just that I was like, you need to move on. It's fine. You need to move on.
I know. I just like things perfect, you know, and I wanted to make sure the colors were right. And yes, I made this myself. It was humbling, but it's been an awesome experience learning new things and learning different programs for design. So yes, painstakingly, humbly.
Which is why, you know, if anybody has feedback or things that they want included, or you're reading it and we speak on IFU on the way your experience, but if someone goes, oh, you know what, we actually started doing this technique, or we started a trial doing these things, to share the information. You know, it doesn't mean it can't be in the book. It's just you only know what you know and what you is public information to reference. But if there's nuanced things that people are doing or trials of new equipment that you're doing, you know, feel free to share with her. And that's, I think you already have, but I definitely think you're on your way to building a community where when you have a first book, it's a lot of your experience and the research that you have access to. But once you start talking to people, like you've already seen in the last couple months, is slowly they're going to start to see their ideas and their contributions in there, right? I talked to this person and they told me about this wire was really helpful for this, and you'll start to put that in there. That I think a lot of other books are missing because a lot of other books are written by physicians and
Hmm.
nothing wrong on that, but they have their practice,
Yeah.
right? They have their practice, their algorithm of this doesn't work, then I'm going here, 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 versus you're in a unique position where you get the input of the community. And a lot of times the techs and nurses are the ones who helped come up with some of those solutions. They just don't get credit for it. Right.
Oh yeah. Well, when you're in a case and you're like been doing the same thing for an hour, then you just start thinking outside the box. You're
We
like,
need to move
okay,
on.
let's do this combination. Let's do this. Let's try that. Like you're just kind of head on a swivel trying anything to make it work. So
Yeah. So I definitely hope that people, and I don't want anyone to feel like to withhold their feedback because feedback is helpful for contribution to continue to build resources that are
oh
for our community instead of for physicians or just to be published. You know, something that actually adds value
yes.
starts as this and then builds into something that you guys want. And if there's things that you guys want, Annie listens, which is where the neuro thing came from. She was like, I can't fit neuro in here.
Oh my gosh, I can't fit vascular in here. I can't fit neuro in there. It's got to be separate. So
Well, I mean, I don't want to read an 800-page book. You know, this is not the Count of Monte Cristo. I want
no,
something that has a start and an end and I can feel accomplished.
exactly. No, please, any feedback. I'm open.
Someone did ask, I'm 3 years into CAF, but we just started doing IR, which sometimes it's because they added an IR suite, but sometimes it's because IR staff quit and they go, Cath Lab, you're doing IR now. That happens
Welcome.
more than you know. Will this help me or is it too advanced?
Oh, this is
I think
absolutely.
it's in between. Yeah.
Yeah, it's not too advanced. However, like we do dive a little deeper into some things, but we've got a lot of combo labs out there now. So we're
Mhm.
getting more cath lab people doing some IR work, and the vascular stuff we do does translate very easily, but the organ stuff is a little different. So this would absolutely help you.
Yeah.
Just understanding why you're doing it, when you would do it, what you need, how the access works, and how to set up for the case, which is your biggest battle.
So, because this has come up too, someone asked about prep.
Hmm.
Is it, I'm not going to say it's 100% always the same, but for the most part, is your draping mostly the same of where something is located?
Yeah, and in this, I do have your prep zones,
Yeah,
like the
I saw
the
some
prep
of that.
zone being like where you're going to towel out, like where you're going to prep and put your towels. As far as draping goes, it's always going to be the same area, but different hospitals have different drapes. So somehow,
Oh, but
like for
just whatever it is might be different, but
your area is going to
target area is
remain,
going to be the same.
it's going to remain the same, and that's why I put prep zones in here so that people can see the zone that you're going to be prepping, which is huge. However, your hospital might not have a neck and chest drape,
Right.
so
It might
that's
just
when,
all be towels and
well,
medium
that's
drapes.
it's arts and crafts time. So now you're
Yeah.
making your own and using like Ioban or something like that to make your waterproof barrier. Now, some hospitals will have like 8 different drapes, and you have perfect drapes for everything, which is probably how it should be.
Yeah.
But you're not going to have that at some of your smaller facilities. So
Yeah.
that's when we get creative. And once you see the prep zone, you can easily modify.
Okay. That's helpful. Yeah. Because then, I mean,
Mhm.
you're always going to chloroprep an area wider. So if it needs to be adjusted, it can be adjusted a little bit because
Yeah.
you're not really going to know. Like you're going to hope where something is relatively in the area, and through ultrasound, you'll kind of figure out if
Yeah.
you need to access a little differently. Well, that's
Yeah.
helpful. Someone asked, is IR something cath lab techs can do? I said yes, but actually, where you work, they're completely separate. So you have only
Mhm.
rad techs where you're at, right? And
Yeah.
nurses.
Only rad techs in my department. So this is going to vary state to state, hospital to hospital on who is doing what. That's why I have in a page in my book, and I'm like, this is who could be doing your procedure. Um, right? So it can be CBT, RCIS for sure.
But
Some
just
facilities
depends.
have it like that. Some areas want only rad techs in the room for IR. It just depends where you are.
And it depends. And I always think that's how it happens is you have a place that says, oh, we prefer rad techs. They're understaffed for 5 years. And they go, oh, we're having to move our cases to another hospital. Wait a second. We need to widen our net. And then they
Yeah.
adjust their rules,
Right. That's how it works.
Yeah. I mean, that's how we got respiratory and sometimes sonography and paramedics into the cath lab, right? Is
Yeah.
some places just couldn't operate that way. And we're like, what? We need to do something else. Because especially if you're a nurse and a rad tech, you have other options. It's not like everybody graduating is going into IR. It's a percentage of the amount of people who are graduating. So you can't even look at a population and say, well, these 3 colleges are graduating this many rad techs, and that's how many are going to work in the IR.
Mhm.
It's a percentage of those people.
Yeah.
It
That's what's
depends what
good
you're
about
paying.
radiology is you can pivot
Yeah,
to a lot of different modalities, which is great.
yeah. You think they're right off the bat going to go, yeah, call sounds great.
Right.
Not if they don't know what it is.
Right.
You
I
know.
don't know. Or they could just be like the adrenaline junkie. That's why I was like, oh, yeah, that's fine.
Cath lab.
I'm in.
Cath lab, neuro, stroke. I'll take it all. But you're right. I think it's a percentage of people, and then it just depends on your area and what they have access to. Because there's some places that do not have any CBT programs, so they've never even heard of it before. So of course, why are they going to have that listed?
Yeah.
But I've personally applied to places that I was not qualified on paper, and they were like, wait, you understand this and you have some procedural experience? I'm like, yeah. And they're like, oh, okay, great, come on. They just didn't know and hadn't
Yeah.
heard of it before, but it didn't mean it was a no.
Right.
And like you said, a lot are multimodality anyway, and they're hybrid labs. So
Yep.
I will say a lot of the multimodality labs here aren't also IR or aren't also neuro. I'd say there's only a handful that are neurocath IR. Most of them are non-vascular, vascular IR, and cath.
Yeah.
But I don't know if that's because neuro is not at many hospitals, period.
It's not.
Yeah.
Usually you have like your comprehensive stroke center and then your other facility. They've been moving towards like the stroke has kind of changed where you do neuro now.
Yeah. Like we did carotids, but we didn't do, was weird because we did carotids and some cerebrals in the cath lab, but we
Yeah.
had a separate IR department that took stroke call and does the intervention part. But we did like TCARs and carotid stenting and stuff. And I was like, shouldn't they be doing that over there? But I think they were just so busy that they couldn't do all the procedures.
Yeah. Or it's like what sometimes it gets political on what physicians are allowed in what space, and you know how it goes.
Yeah. No, the neurologist never came. They came for TCARs.
Mm-hmm.
And he scared me because I didn't know how to cradle the table because it was a new table. And
Yeah.
TCAR, they have it open, and he's like, "Can you cradle the table while he's here in the carotid?" And I was like, "I don't know how, and I don't think now is the time to experiment."
Right.
So,
Just
and
like
I looked at
question
my
stuff.
cardiologist. I was like, "Do you know how to cradle the table?" He's like, "No, you guys do that." It's like, awesome. Of that, nobody knows how to move the table, but it's my fault.
Right. You can't know everything.
I've never done a TCAR before or been in this room, but my name was on the board.
Great.
Someone asked, can I use this? And I say this in your comments too. Can I use this for the VI exam? And then what do I need to supplement? Because I have no idea what it covers.
Yeah. So this specific book is going to cover all your non-vascular procedures and your central venous accesses, which is absolutely on the VI exam. A great resource for that for supplementation. Once I have the other books, that will complete the full VI series. But yeah, I've been teaching the internship for which we specifically teach to have them succeed in the lab, but the final thing they do is take the VI exam. So since I've been teaching that for so long, I put all that information in here too.
Yeah, I saw you put, and I think it's relevant outside of it, but I saw little like VI board boost stickers.
Yeah.
But I guess you're right. Regardless, like you need the foundational stuff anyway.
Yeah, that patient care, sterile technique, imaging, that's a big part of the VI exam. That's in there too.
Like do they give you like, I don't know. Is it,
Oh yeah.
it's not, is it all multiple choice or is it like hotspot, like the RCIS, where you have like a picture and they're like, click here on where this artery is,
Yeah,
click here on where this is.
well, you have to. A lot of it's multiple choice, but then some of it's like put things in order.
Mhm.
There's different types of questions on it.
Okay. Because I would say the CI, and I might not be accurate, but I read
Mhm.
the information on it. It said multiple choice only. I was like, is it? Or did you guys just not update your description?
I don't know. I don't
So
know.
I have to ask. I asked someone and they said that, but I don't know. I'm like, is it also just the question mix you're getting was all multiple choice? Because I'm scared to say it's only multiple choice, and then someone messages me and goes, it was not only multiple choice. I'm like, I'm
Yeah.
sorry. I'm not all knowing. Someone put a question in the chat and said, I just applied for a cath lab rad position. So I guess rad tech in the cath lab and got shortlisted. I'm excited and nervous because I'm currently practicing intra-op C-arm imaging for ORIF. What is ORIF?
Oh,
Do
that's
you
like
know?
when they reduce like the ankle. You have like an ankle fracture and the X-ray.
Oh, and laminectomies. That
Yeah.
makes sense then.
Yeah.
Any advice before the interview?
Oh, before
And
interviewing for IR, and well, tell them that you do OR.
you think that's helpful?
Oh gosh, yeah. Like if you,
But see, do you think she's doing, and she's not scrubbing in, but you think just doing the imaging part is still
oh yeah, because a
helpful?
lot of the like running the C-arm, a lot of the functions are going to be the same. It's just you're putting it to a table side control in IR, whereas you're
Hmm.
doing it like on the C-arm, like
Got it.
standing in the back. So a lot of it's the same.
I mean, it's still a procedural area. So even like I mean, I know this sounds silly, but you know what not to touch.
Oh, for
A lot
sure.
of people don't even know that, like what
Yeah.
swelling is.
Yeah. I would be letting them know like I currently already work in the OR. So the people and I are going to say, okay, great. You know how to operate a C-arm.
Yeah.
Yeah, we're going to have to teach you some nuances and how to do cone beams and do some of the more advanced stuff. But that battle is kind of already great. You already have a basic understanding, which is awesome. People that do well in IR usually worked in the OR in X-ray
Oh,
before.
really?
Yeah. So mentioning that is a huge one. And then willingness to learn. Say, hey, I'm willing to do anything. I'm ready to hop in there. Um, just showing like I'm gonna tackle this head on.
Yeah. So show your
Mhm.
experience, but acknowledge the gap at the same time.
Yeah.
So
And that you're
this will help me be positioned to learn because I understand like all the organ systems you cover, that I have a lot, you know, to learn
yeah.
on all of that stuff.
Yeah.
She also asked, how can I access this book in soft copy? So when people say soft copy, they mean digital. And the answer is you cannot.
No digital.
No,
No digital.
physical only
Just hard.
there is.
Yep. Physical only.
Because unfortunately, people are a little wild on the wild side. So I
Yeah.
would say never, but for right now,
Hard
physical
copy.
copy only, hard copy only. But you do, I mean, you have a minimum free shipping, but in the US, it's free shipping. Like this qualifies for free shipping. So
Yep.
easy peasy lemon breezy, in my opinion.
Yes.
But it is also huge. I don't think I would want to scroll through all that digitally anyway. I kind
Oh,
of
that
like
would.
this.
Yeah.
But I mean, some people are like that, right? Some people like, it's not nostalgic, but some people just operate this way.
Yeah.
Some people don't. But I think you cover a lot for sure. Um, where can they buy it? If their hospital needs to buy it, what do they need to do? Close us out.
So you can buy on Shopify, and we just listed on Etsy as well. If your hospital wants to buy for you, just shoot me an email and then I can get you an invoice and a copy of our W-9 because they usually use that. And we can get you a draft order that they can easily fulfill or easily pay. And if they can't pay on the website, we will work around it. Just email me. I got you.
Yeah, I think half of it is just asking and showing them where they can get it. You know, it never hurts to ask. Worst they can say is no, but some people have hidden education budgets. You never
Yes,
know.
they do.
You never know.
Mm-hmm.
I think that's it. Did I
Well,
address
thank you.
everything? Anything you want to address that I didn't address?
No, thank you
Well, I
so much.
appreciate the walkthrough. and answering people's
Doctor.
questions.
Mm-hmm.
I think we can come on one time and do some sort of specific topic, or just if someone brings something up to me that they want to talk about. But you should feel more comfortable in lives now. It's not bad.
Yeah, because I'm like just looking at you and not
It's okay. It's a little nerve-wracking because you never know what people are going to say, but people are usually nice and just pop in their questions and are like, I'll look at the answer later. So it's all good. Any timeline on next books? Good question. She's probably crying inside from you asking that question.
ASAP. I don't know. I'm ready to
In
tackle the next
progress.
thing.
Well, you've done the
Yeah.
outline already, right?
Mhm.
Pretty much.
Outline's done. Probably going to drop something small next. And
Yeah.
then after that, another big book. But yeah, I'm excited to pivot. I worked on this first non-vascular book for, it's probably been a year and a half
Yeah,
almost,
I'd say.
right?
And
Just
your first one always takes longer because you don't know your flow
yeah,
of how you want to organize things, what your writer's blocks are triggered by, how you get through them. You know,
yeah,
you're figuring all of that out. You just don't know.
yeah. I am. Yeah, I have no doubt the other ones are going to be much quicker because I have my
I'd
plan
say
to it now.
next, like end of next year. You think? Maybe.
Sure,
Is that too ambitious?
we'll see how it goes.
That'll
Um,
be the goal. around that. I mean, I always said that. I said that with my EP book, and then a year later, people are like, "Didn't you say this is coming out next year?" I said, "Yes."
sure did. Well, no,
I do. But you
I
like neuro. Neuro's like your
I love neuro. I
second nature for
love,
you.
yeah, I love the vascular stuff. So because I mean I love IR in general, but because there's such passion behind those two, usually when you're working on something like that, it just kind of flows
Yeah,
a little easier.
I agree with that.
Mhm.
So there's your answer. She said, "Sorry, but this is incredible." It's okay. It's an author problem because we want things to come out as fast as we can think and draw, and that just doesn't happen.
That's frustrating. It's frustrating.
Yeah, yeah. Just like I just want all of this out now.
And now, like, yes, I wish I had all three right now, but it
Yeah.
just takes a little time.
I mean, there's always the easier way to do things, right? But then it never comes out quality. So taking your time is not a bad thing.
Yeah, I think people can see that when they open the book.
Yeah.
A lot of
Like, oh,
time.
she spent a lot of time with this. Yes, we don't use AI garbage. There's a time and a place. This is not the time and place.
No, it's not.
Well, thank you. I saw Eric featured in some of the pictures in the book. I'm assuming it's
Oh no,
him.
no.
We want
That is not Eric. Eric would not pose for the
really?
pet pictures. So that is my friend Nick,
Oh, why
who
wouldn't he do it?
he was like, Nick works out all the time. Make Nick do it.
I was gonna say whoever it is does have good like jaw structure for the IJ prep.
Yeah,
Go
so that's
mad.
Nick, who graciously was my model one day, and we did. Oh, Eric's like, no, tell them it was me.
I mean, that's just I was like, wow, look at Eric's jawline in this IJ prep. It's really
No, it
good.
was Nick. He literally like
Nice.
laid on a table with a mat on it that I had like a white sheet in my kitchen to do those pictures. Anyway,
Imagine your parents or your kids describing at school one day. What'd you do over the weekend? Well, my mom was taking some pictures of this person on our kitchen table.
mom was doing surgeries in the house. They're like, what?
Yeah, yeah. Like what?
What?
We were discussing, sorry, there was a question in the comments. We were discussing her IR book, Interventional Radiology book, if you do that. So it goes over all the organ systems, prep, sterile technique, and then the back end, we were discussing the neuro book that comes out. But I will send this live to her, and supposedly she's going to edit it and upload it to YouTube. So you should be able to rewatch everything. If you have any further questions, I think she should be tagged in here somewhere. You can directly message her or comment on any of her posts, and she'll be happy to answer you.
Okay.
All right.
Thank you.
You're welcome. Thank you so much for being here, and have